Hello everyone, I'm Dr. Deepti, and today I just wanted to bring across to you a sample video discussion of the live TND session that we would be conducting or starting from 7th of June, right? Looking at the current pattern of exams, whether it is Central Institutes or NEET or NEXT, which would be coming up. The pattern of these exams now is clinical oriented as well as integrated. Right, so it's no longer about single lines or most commons. So these are long stem questions where they're trying to integrate a couple of topics together and trying to reach or see whether the students can do this integration and reach the correct diagnosis or next step and so forth in the discussion. So we are, as I said, we are going to start a live test and discussion course on the eMedicoz app, which is going to start from 7th of June. In this TND session, we would be including papers which are more clinically oriented and which have a lot of integration and long stem clinical questions. And this, as I said, is going to be a sample video on how we are going to do this discussion with respect to a case and how do we do the within the case itself, right? So let's look at the question for you all, and then I would be discussing the topic as well or relevant things for the topic as well. Okay, so this is a 23-year-old woman. She is 20 weeks pregnant, right? And she undergoes an ultrasound examination because her uterine size was larger than dates. The ultrasound reveals hydramnios with an amniotic fluid index of 30 centimeters. Now, the fetal abdomen reveals a cystic mass in the right abdominal region and a cystic mass in the left abdominal area. Which of the following is the most likely associated condition? So this is a question which integrates 2 or 3 topics together. And then we need to, once we integrate them, we pick up the clinically important keywords, put them together and try and reach the answer. So the first important thing that I would like to highlight here is when the fundal height is more than the period of gestation, then you should all remember that one of the important reasons for this would be polyhydramnios. Yes, so one of the important reasons for this would be polyhydramnios, which is already given in the MCQ as well. And the various ways of measuring the amniotic fluid are either amniotic fluid index or a DVP, right? Deep vertical pocket, again, which is already given to us. So now let us try and see this. The amniotic fluid index, we all know the normal values are from 5 to 24. And for deep vertical pocket, it is from 2 to 8. And this patient has an amniotic fluid index of 30 centimeters, right, which is very significant. So if we divide polyhydramnios into mild, moderate, and severe, right, these are the categories, or this is how we categorize. So from 24, and some textbooks say from 29. So from 24 to 29.9 is what we take as mild polyhydramnios, right? And for moderate, we would say it is between 30 to 34.9. And severe would be if it is more than or equal to 35. So this patient falls into the category of moderate polyhydramnios. Why is this important to know? Because when we talk about mild and moderate and severe, the relevance here is that if it is mild polyhydramnios, the most common cause is actually idiopathic, right? So the most common cause is idiopathic, and there would not be any significant finding in the baby. But once the MCQ says there is a moderate to severe polyhydramnios, or this is what you see in clinics, then this means you should definitely look for gross congenital anomalies, and which is what we did for this baby. So we have done a level 2 scan for her, and this is again clinically significant information. The question says we've done a scan at 20 weeks. So yes, the level 2 ultrasounds are done between anytime between 18 to 22 weeks. And this is a anomaly scan, also called as a TIFA, targeted imaging for fetal anomalies. And it is significant for this patient. So once you're doing an anomaly scan, you are seeing a cystic mass in the abdomen on the right side and another cystic mass on the abdomen on the left side, right? So we are finding a congenital anomaly. And what is the likely congenital anomaly? Where you would see two cystic masses in the fetal abdomen. So this is a case of duodenal atresia, right? So this is a case of duodenal atresia, right? And if I show you the image for it, this is the characteristic double bubble sign, right? So that's the classic double bubble sign that you see on ultrasound or an antenatal ultrasound, and it is a marker of duodenal atresia. So now we pretty much know what is the patient suffering from. So she is, if I put it, in a concise way for you, so she is a patient who has gross polyhydramnios, and on evaluation, the baby has a congenital anomaly. The baby has duodenal atresia. Now, once you've got this information, we go on to see what the options are saying. The question is saying which of the following is the most likely associated condition, right? So our options are A, it says gestational diabetes, B, congenital ovarian tumors, C, Down syndrome, and D, Rh isoimmunization. Let's try and take one or each option one by one. The first option says gestational diabetes. So what are the points which is not the answer here, right? So what are the points that go against a diagnosis of gestational diabetes? The first point which goes against the diagnosis is that gestational diabetes does not produce congenital anomalies or gross congenital anomalies. Okay, gross congenital anomalies are rather a feature of pre-gestational diabetes. Okay, and it is this pre-gestational diabetes which causes hyperglycemia during the period of embryogenesis. Okay, and the hyperglycemia being fetotoxic causes anomalies in the baby. The second point which goes against, so even if you get confused or you say, I did not read the word gestational, still diabetes would not be the answer. Why? Why would diabetes not be the answer? Now, diabetes no doubt is associated with polyhydramnios, okay? But it is usually associated with conditions of mild polyhydramnios. It would not usually cause moderate to severe degrees of polyhydramnios. Secondly, diabetes does not generally produce GIT anomalies. The classic anomalies which have been described in overt or pre-gestational diabetes, right, are, so what are the most common anomalies? The most common anomalies that you would see in the fetus in pre-gestational diabetes are cardiovascular followed by neural tube defects, right? So more commoner anomalies are not GIT anomalies. It's usually cardiovascular or neural tube defects, right? Whereas if we talk about the most specific anomaly, and mind you, there were a couple of MCQs this year in NEET from whatever we are discussing right now, right? So most specific anomaly for diabetes is sacral agenesis or caudal regression syndrome, right? So as I said, the baby in question here or the fetus in question here does not have a cardiovascular defect or a neural tube defect or a sacral agenesis. The baby has defects in the GIT system, right, which are not characteristic to diabetes. The second reason I said which goes against the diagnosis is that diabetes would usually cause mild polyhydramnios. And what is the reason for polyhydramnios in diabetic pregnancy? The reason is polyuria by the fetus, right? So baby also has hyperglycemia, which causes, polyuria. And the second reason is that the amniotic fluid will also have high levels of glucose, right? And this is going to cause osmotic movement of water into the amniotic fluid, which results in poly, right? So there is osmotic fluid movement, which results in polyhydramnios. So yes, diabetes is an important cause of poly, but this is not the etiology in this particular pregnant women. Let's go on to the second option given to us. It says congenital ovarian tumors. Now, yes, there is a possibility that in congenital ovarian tumors as well, you would see cystic masses, right? So that is why it has been put in the differential diagnosis. But it is not a very common thing to come across. What goes against the diagnosis of congenital ovarian tumors, or option B? Congenital ovarian masses or cysts, okay, in the fetus are generally going to be unilateral, right? Whereas in this baby or fetus, we are seeing one ovarian cyst, one cyst in the abdomen on the right side and one on the left side, right? So whereas congenital ovarian cysts tend to be unilateral. Then the requirement to make a diagnosis of congenital ovarian cyst in the fetus is that there should be the cystic structures should be non-midline, which is okay. Here they are non-midline, one is on the right, one is on the left. They should be non-midline swellings. Second thing is that the urinary tract has to be normal looking. The urinary tract should be normal. And the third requirement is that the GIT tract should be also normal looking. Why? Because these are more commoner areas of anomalies that you are going to find them. So when you're going to make a rare diagnosis for congenital ovarian cyst, you ensure that you're not mistaking them for a urinary tract cystic swelling or a GIT cystic swelling, right? And yes, they will be seen in a female fetus. The reason to see congenital ovarian cysts is hormonal stimulation. They are not something to be worried about. They are usually the follicular cyst in the fetus, and they would spontaneously resolve, right? Very, very important, congenital ovarian cyst will not be associated with polyhydramnios, and that is why they are not the diagnosis here, okay? Let's look at option D. Option D says RH isoimmunization. Yes, so RH isoimmunization is a condition which can be associated with hydrops fetalis, right, or heart failure. And if there is hydrops fetalis, what happens is, as a regulatory mechanism, the baby is going to have polyuria, right? And this polyuria in RH isoimmunization is going to contribute to polyhydramnios. But why is it not the diagnosis here? First, we have not given in the MCQ that she is an RH negative pregnancy. And secondly, RH isoimmunization would not be associated with duodenal atresia, right? So here we don't simply have polyhydramnios. We have a combination given to you. The combination given is poly and duodenal atresia, right? So by exclusion, the answer comes to be C, or Down syndrome. Now let's explain how this is the etiology of the condition here. Now when I said we come across moderate to severe polyhydramnios, the reason is gross congenital anomalies. And one of the important things that I would like to ask you here is, why should a baby have GCA? Why should a baby be anomalous? So one of the important reasons why a baby would be anomalous is chromosomal abnormalities, right? So probably the baby's chromosomal makeup is abnormal, which is resulting in, and duodenal atresia here, I hope you know, has a very strong association with Down syndrome. It's a characteristic GIT finding in the babies of Down syndrome, right? You have to know this. This is important. Right? Not only this, in the exams, they would also ask you this. There is a condition called as gastroschisis, and there is a condition called as omphalocele. Right? And we are quite fond of asking you, which of these would you actually see in a baby of Downs? So Gastroschisis is usually not seen in a baby with Down syndrome, while omphalocele is what is seen or can be seen in a baby with Downs. Remember, it is omphalocele which is associated with chromosomal abnormalities. So you are likely to see other gross anomalies in the baby as well when the fetus shows the omphalocele, right? Gastroschisis is usually not related to other anomalies, right? So duodenal atresia is the characteristic GIT finding in the baby of Downs. Coming to explanation of why should a baby of duodenal atresia have poly. So if we talk about regulation of amniotic fluid, right, the two important mechanisms for regulation are fetal swallowing and fetal urination, right? Anytime the baby is not able to swallow, right? So when this fetal swallowing is absent, it will contribute to polyhydramnios. And anytime the fetal urination is in excess, it will contribute to more amniotic fluid and it will result in polyhydramnios. So the explanation here is defective fetal swallowing. So in duodenal atresia, you will come across defective fetal swallowing, which is the reason why we are seeing polyhydramnios, right? So a single MCQ, but had a lot of integration. You had to know about poly, you had to know about Downs, you had to know about etiology of, polyhydramnios. How does it happen? You had to integrate it with, a clinical finding, which is chromosomal abnormalities, and then reach to the answer. Also, please remember when we talk about polyhydramnios, I have already enumerated for you, but just to, towards the end, would like to tell you that these are the most important causes of polyhydramnios, right? So important reasons are structural abnormalities, right? By which I mean gross congenital anomalies. And whenever you do come across gross anomalies, look out for chromosomal anomalies, which is the second important association of poly, especially in the presence of structural abnormalities. Then whenever the fetus has a high cardiac output, right? Because then the baby tries to compensate by doing polyuria. So fetal anemias can be associated with polyhydramnios. Conditions like RH isoimmunization, where the reason is again the same, it's heart failure and it's polyuria, right? Twin transfusion syndrome is another such condition, okay? Then diabetes mellitus, we've already explained why you would see polyhydramnios in a diabetic pregnancy. Fetal infection, okay? And especially parvovirus B19, right? So please remember, parvovirus B19 is associated with fetal anemia, and that is why it can be associated with polyhydramnios. And lastly, not a very common thing to come across, but yes, you should know this. It is a likely question for your upcoming exams, and it is fetal Bartter syndrome. So in the fetal Bartter syndrome, there is again polyuria, and as a result of which there will be polyhydramnios. Whereas in Liddle syndrome, right, there is going to be oliguria, and there is an association with oligohydramnios. So these are important associations when you come across polyhydramnios. In most of the cases, if it is mild poly, it would be none of these, right? So mild polyhydramnios most commonly is actually idiopathic. So if it is mild, 40% of cases do not really have any underlying cause. They do not have any poor outcome of pregnancy, and you do not need to do anything specific for it. But you definitely need to rule out these things if you come across moderate to severe polyhydramnios. So I hope you found the discussion of the question useful. I hope you understand what we mean by clinical integration and how to put your basics together to reach to an answer. And as I said, this was a sample discussion of how we would be conducting the live test and discussion sessions on eMedicoz, which is beginning from 7th of June. To be a part of the course, you just have to download eMedicoz, and you can purchase the course right from the app itself. And the live TND sessions on eMedicoz are going to include the test series as well as the DAMS question bank with it. The test series are again based on latest patterns, and they all come with video discussions. The DAMS question bank is going to come with all new pattern MCQs, which includes match the following, extended matching questions, multiple completion type questions, as well as clinical vignettes. Right? We are also constantly adding new material to the DAMS question bank, which include video-based questions, and anything new pattern which is going to come up, it keeps getting edited into the DAMS question bank. Right? I hope you find the discussion useful, and we will bring you more such sample videos for the upcoming live TND session. Best wishes and lots of love, Dr. Deepti.